Hi, okay. I'm George Benjamin. I'm the chair of the committee, and I'm going to read this disclaimer, which is something we have to read for any kind of meeting that we're having of this type. And so it says, as chair of the committee for the analysis to enhance the effectiveness of the federal quarantine station network based on lessons from the COVID-19 pandemic, I would like to welcome everyone to the open session of the committee's first meeting. I want to note that this is an open, on the record, information gathering session. That is, the committee is in the process of assembling materials that will examine and discuss in the course of making its findings, conclusions, and recommendations. Therefore, I ask everyone here today to be extremely mindful of the fact that the committee has made no conclusions and that it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or of the academies. So this is the first of approximately 4 to 5 full committee meetings. Some of these meetings may include public sessions, which will have the opportunity to hear from experts in the field, and the committee will deliberate thoroughly before writing its draft report. Moreover, once the draft report is written, it must go through a rigorous review of experts who are anonymous to the committee, and the committee then must respond to this review with appropriate revisions that adequately satisfy the Academy's report review committee and the chair of the National Research Council before it is considered an NRC report. The expected report release is May of 2022. Now, further information on the study, including future meetings, can be found on the project website. The open session today provides an opportunity for the sponsor of this study to address the committee and describe the context and reasoning that went into the committee's statement of tasks so that we can better understand the scope and purpose of this study. After hearing from the sponsor, the committee will go into closed session, and then we'll have another open session at 1:15 where we get a history lesson on the use of quarantine to prevent disease transmission. During the Q&A session and discussion, the committee questions and comments will take priority. The public can, of course, submit comments to the study, email, address it, and list it on the project website. And of course, this meeting is being recorded. One of the reasons we record this meeting is to assist with notes. And of course, today our goal is to orient the committee to the National Academy's consensus study process, to hear from our sponsoring agency on their perspective of the statement of tasks, and external speakers to get a landscape on the issues related to the statement of tasks. We will have speakers join us from the CDC to better understand how the Division of Global Migration and Quarantine operates. And I would like to ask the committee to briefly introduce themselves. So what I would like you to do is, if you would go around and introduce yourselves. Obviously, there's no order to this, but if we just give, because we'll have a chance to go into more depth amongst our backgrounds later when we do our bias and conflict discussion. But if we could just introduce ourselves with your name and right now what your position is where you work, that would suffice. So to emulate that, I'm George Benjamin, and I'm the executive director at the American Public Health Association.
I'm Reuben Warren, and I'm professor of bioethics and director of the National Center for Bioethics and Research and Healthcare at Tuskegee University. Good morning.
Good morning. I'm Michelle Berry. I'm the Dean of Global Health at Stanford and the Director of the Center for Innovation of Global Health at Stanford.
Good morning. I'm Ed Ryan. I'm the Director of Global Infectious Diseases at Massachusetts General Hospital, and I'm Professor of Immunology and Infectious Diseases at the Harvard Chan School of Public Health.
Good morning. I'm Bradley Dickerson. I lead Sandia National Laboratories Global Chemical and Biological Security Group.
Good morning. I'm Lawrence Gostin. I'm a professor of global health law at Georgetown University and director of the World Health Organization Collaborating Center on National and Global Health Law.
Hello. I'm Anna Abreu Lanza. I'm the Vice Dean of New York University's School of Global Public Health and Professor of Social and Behavioral Sciences.
Hello, I'm Alessandro Vispignani. I'm a professor of computer science and health sciences at Northeastern University in Boston, and I'm the director of the Network Science Institute.
And I'm Steve Ostroff. I currently have adjunct appointments at the Graduate School of Public Health at Pitt and at Penn State College of Medicine, formerly worked at both FDA and CDC.
Good morning, I'm Lonnie King. I'm Academy Professor, Dean Emeritus at the College of Veterinary Medicine at The Ohio State University.
Good morning, Moon Kim, medical epidemiologist with the Acute Communicable Disease Control Program at the Los Angeles County Department of Public Health.
Good morning, I'm Yetza Bojorquez. I'm a professor researcher in the Colegio de la Frontera Norte in Tijuana, Mexico.
Hi, I'm Jason Wang. I'm a director for Center for Policy Outcomes and Prevention at Stanford.
So is that the full committee?
I think it is.
Howard, we will introduce you later. And Julie Pavlin. Julie, you want to introduce yourself?
Sure, I'm Julie Pavlin. I'm the director of the Board on Global Health and currently the acting study director for this study. And I have a great team supporting me. So we might just wait until we have our closed session, then we can kind of get to know each other a little bit better and we'll move on. But I'd like to hear from the CDC.
And if you could just introduce yourselves as well, Jennifer and Brian.
Sure, good morning. My name is Jennifer Boygoot. I'm the Associate Director for Policy and Regulatory Affairs in the Division of Global Migration and Quarantine.
Hi, I'm Brian Maskery. I'm an economist at the Division of Global Migration and Quarantine, and I wanted to make sure people could see my screen. Yeah, okay.
Yes, we can see the slides. Great.
And should we just start, or did you want introductions by the rest of DGMQ?
If there's someone else on the line, then we would love to hear who else is here.
Sure. I'll wait for everyone else to introduce themselves.
Hey, George and Julian and friends and others, colleagues. This is Marty Cetron. I'm the director of Division of Global Migration and Quarantine. I'll be offering some remarks later in the second session today, open session. Back to you. There are some of my other colleagues that are on. I'll just toss it, and each of you, if you could toss to one other person that's on. So Dr. Clive Brown, go ahead and introduce yourself.
Yeah, hi, I'm Dr. Clive Brown. I'm the chief for the Quarantine and Border Health Services branch within the Division of Global Migration and Quarantine. And Francisco.
Good morning, this is Francisco Alvarado. I'm the Chief Medical Officer for Quarantine and Border Health Services at CDC.
Hi, this is Lisa Rotz. I'm the Deputy Director for the Division of Global Migration and Quarantine. Thank you. And I'll toss it over to Andy Klebos.
Hey, good morning, everyone. I'm Andrew Klebos. I'm a regional officer in charge with the Quarantine Border Health and Services branch under DGMQ. And I'm not sure if anyone else is on, so anyone else from DGMQ.
Okay. So well, thank you very much. Jennifer and Brian, back to you.
Sure, and we wanted to start off by saying thank you to the National Academy of Science team for putting together this excellent expert committee, and to thank the expert committee for their time and consideration in improving DGMQ as we move forward. We will begin with an overview of the Division of Global Migration and Quarantine. DGMQ's mission is to protect the health of US communities in a globally mobile world. DGMQ focuses on the people who migrate and the places where we have an opportunity to take action to curtail disease spread. DGMQ protects public health at US ports of entry. by rapidly responding to sick travelers who arrive in the United States, alerting travelers about disease outbreaks, and restricting the importation of animals and products that may carry disease. DGMQ keeps Americans healthy during travel and while living abroad by reducing injury and illness among US residents traveling internationally or living abroad through alerts, recommendations, education, and support based on the best science to travelers and healthcare providers. DGMQ ensures the health of individuals coming to live and work in the United States by overseeing the mandatory health screenings for all immigrants and refugees entering the United States, as well as oversees vaccination and parasite treatment programs. DGMQ partners to protect the health of US communities along the US-Mexico border by working with state, local, and Mexican public health institutions to detect, notify, investigate, and respond to reports of illness and infectious disease among residents and travelers in US communities along the US-Mexico border. By creating a multi-layered system of public health defenses to mitigate the risk of communicable diseases spreading into and within the United States, CDC's global migration and quarantine activities expand the perimeter of US public health security to other countries where diseases may originate and where interventions are often more cost-effective. I also want to highlight that DGMQ is unique within CDC in that it has delegated regulatory authority to take actions to prevent the introduction, transmission, and spread of communicable diseases. The COVID-19 response has used many aspects of CDC's regulatory authority that will be highlighted later in this presentation. DGMQ monitors emerging threats around the world and the ways in which these threats affect mobile populations and their communities, including immigrants, refugees, and migrants, travelers and expatriates, and binational populations. We will briefly introduce 3 branches and 1 unit within DGMQ. The Quarantine and Border Health Services branch at the top, Immigrant, Refugee, and Migrant Health branch on the right, the Travelers Health branch at the bottom, and the US-Mexico Border Health Unit on the left. There are more than 320 ports of entry that process more than 300 million international travelers every year, at least in the pre-COVID time period. 20 quarantine stations have been established in international airports or at land border crossings as shown in this map. The land borders are at San Diego and El Paso. About 85% of arriving international travelers enter through these major ports of entry. Each station has a jurisdiction for other ports of entry as shown in the map. For example, the Seattle quarantine station in the Northwest covers all 4 of the purple states, Washington, Oregon, Idaho, and Montana, and the ports of entry within those states. The number of quarantine stations increased to 20 between 2004 and 2007 because of concerns about bioterrorism and the worldwide spread of disease after the SARS outbreak. However, in recent years, the Boston and Dallas quarantine stations were not staffed due to budget constraints. However, with COVID-19 supplemental funding and the need to quickly stand up entry screening, the Boston and Dallas quarantine stations are now fully staffed. Staff at these stations work closely with Customs and Border Protection and other partners to identify and respond to ill travelers, inspect animals, animal products, and human remains that pose a potential threat to human health. They also screen cargo and hand-carried items for potential vectors of human infectious diseases. CDC works to improve the health of immigrants, refugees, and migrants and prevent the importation of infectious diseases and other conditions of public health significance into the United States by these groups. A medical examination is mandatory for all applicants outside the United States, applying for an immigrant visa and for all refugees coming to the United States. Outside the United States, medical examinations are performed by approximately 600 physicians called panel physicians selected by the Department of State or DOS. People already in the United States who apply for readjustment of their immigration status to that of permanent resident are also required to be medically examined. These medical examinations are performed by approximately 5,000 physicians called civil surgeons. So if they're in the United States and changing status, they're called civil surgeons as opposed to the overseas ones, which are called panel physicians. Civil surgeons are designated by the Department of Homeland Security's U.S. Citizenship, and Immigration Services, or USCIS. DGMQ provides the DOS and USCIS with medical screening guidelines, referred to as technical instructions for all physicians performing the overseas and the US-based medical screening examinations of refugees and immigrants. DGMQ uses webinars and international workshops to support training panel physicians. DGMQ also works with the Department of State to provide pre-departure vaccinations and presumptive parasitic treatment to US-bound refugees. We have achieved high coverage rates for these programs and have conducted economic evaluations that have shown that pre-departure provision of these services is much more cost-effective than post-arrival programs would be. CDC also notifies state and local health departments of the arrival of refugees to their jurisdictions and provides states with overseas medical screening results and treatment information for each refugee and immigrant with certain conditions. Travelers' health. Travel is integral to global economies, but has also been associated with the rapid international spread of infectious diseases, as we've seen clearly over the last 2 years, given the challenges posed by COVID-19. DGMQ wants to facilitate and support the movement of people while we work to ensure that people on the move are healthy and not vectors of infectious diseases of public health concern. When outbreaks occur, DGMQ posts travel health notices to give travelers and other interested parties details about ongoing outbreaks and other acute health threats occurring outside the United States. Travel health notices also provide travelers with detailed health and safety guidance, including what precautions to take to mitigate against identified outbreaks and acute health threats at the intended destinations. Appropriate precautions may include pre-departure vaccinations, such as for measles, and/or recommended protective measures to be taken while abroad. DGMQ's partnerships with travel health physicians around the world provide key intelligence concerning disease hotspots. DGMQ, this is about the US-Mexico Border Health Unit. DGMQ works to improve the health of migrating populations through public health partnerships, including having staff based in Mexico City, science and response at the US-Mexico land border. We share an almost 2,000-mile border with Mexico, and given the number of people that cross the land border daily, it's among the busiest in the world. DGMQ partners with other federal agencies, as well as local and state health departments for preparedness activities at US points of entry. Public health officials and partner agencies are our eyes and ears on the ground to detect, notify, and investigate reports of communicable diseases in the border region. We also work to strengthen surveillance and laboratory capacity in the border regions and in Mexico. This binational collaboration improves our ability to identify pathogens, follow disease trends, and identify outbreaks. Another unit in DGMQ that I will mention briefly is the Community Interventions for Infection Control Unit. This unit conducts research on non-pharmaceutical interventions, or NPIs, for influenza pandemics and other respiratory disease threats. It educates communities through NPI guidance, supports the adoption of policies that support non-pharmaceutical interventions, and engages partners in NPI research, policy, and communication. DGMQ supports regulatory responsibilities that have been delegated to CDC. For example, the laws and regulations provide CDC with authority to develop protocols for panel physicians throughout the world who conduct medical examinations of immigrants and refugees before their admission into the United States, implement public health interventions to reduce communicable disease spread with respect to humans, animals, and cargo, conduct health screening at ports of entry for quarantinable or other serious communicable diseases, for example, Ebola and COVID-19 in the recent past, and limit or prohibit importation of animals or items that may be linked to communicable disease spread. Now I will focus on emergency responses undertaken by the division. As you can see in the slide, we are an important piece of almost every emergency response at the agency. And although we frequently receive supplemental funding for large responses, Our base appropriation has remained relatively flat for most of the previous decade, despite the increasing responsibilities of the division. This can constrain our ability to respond as quickly to new threats as would be ideal, as we often have to wait for the funding to be received, which might be a few months into the response. Next, I will highlight some of the successes of the division, which can be credited to our hardworking staff who have had to work on overlapping emergency responses many times over the previous decade. First, I'll cover a couple of non-COVID highlights. As a result of the immigrant medical exams, in a typical year, up to 1,000 individuals with infectious TB or tuberculosis are treated before they arrive in the United States. These efforts help to prevent the spread of TB into US communities. We also published the 2020 Yellow Book, which is the definitive guide for international travel recommendations, and we are currently working on the 2022 version. Moving on to highlight several COVID accomplishments. At the start of the COVID-19 pandemic, we started screening international air passengers and continued doing so through September 2020, at which time we'd screened over 766,000 passengers. We launched the COVID-19 Travel Planner to help travelers make informed decisions about domestic travel. We issued over 1,000 travel health notices during the first 6 months of the COVID-19 pandemic and have continued to issue these notices to help inform international travelers. Lastly, we used our regulatory authority to an unprecedented degree to protect the public by issuing a number of orders. As you can see from the list of orders, we have taken a variety of actions from requiring people to wear a mask while traveling to requiring a negative COVID test prior to arrival in the United States. I will now turn it over to Jennifer Boygoot to discuss regulatory actions undertaken as part of the COVID-19 response. Some questions to consider during this part of the presentation include whether we may be doing too much or too little on the regulatory front, whether the mix between international and interstate regulations is appropriate, and whether some orders, like for example, the eviction order, may be better administered through other federal agencies while using public health authorities. So I'll turn it over to Jennifer now, and thank you.
Thanks so much, Brian. Can everyone see my screen? Okay,
Yes.
Great. So as Brian mentioned, I will go over a little bit of in more detail, the regulatory actions that we've taken specific to COVID-19. So at the beginning of the response and pre-COVID, CDC would issue maybe one federal isolation order per year, and that was frequently for infectious tuberculosis. And CDC had not issued a federal quarantine order since the 1960s during a smallpox outbreak. So then, of course, fast forward COVID-19, and at the beginning, we issued, and as you can see, over 3,000 federal quarantine orders from January through March of 2020. The initial group that received federal quarantine orders were repatriated individuals from Wuhan, China, and some individual travelers from Wuhan who arrived on commercial aircraft were also issued quarantine orders over the very beginning months. The next group were travelers that were disembarking from the Diamond Princess cruise ship that had been docked off the coast of Japan. And finally, the largest number of quarantine orders were issued for passengers on the Grand Princess cruise ship at the port of Oakland in California. And most of those individuals who were issued quarantine orders were housed on military bases. Next, there was the no sale order followed by the conditional sale order. And these orders included a number of documents that helped contain outbreaks on ships, including technical instructions and the safe resumption of cruising that happened earlier this summer. And after the expiration of this temporary extension of the conditional sale order, CDC intends to transition to a voluntary program in coordination with interested cruise ship operators and other stakeholders to assist the cruise ship industry to detect, mitigate, and control the spread of COVID-19 on board cruise ships. The next one is related to the, and did I go? I went too fast. There we go. It's related to the pre-travel test requirement for air passengers. And this order went into effect on January 26th of 2021, earlier this year, and it applied to all arriving international travelers, and they were required at the time to prevent a negative COVID test within 3 days of departure. And as mentioned, this was required of all airline passengers, including US citizens and lawful permanent residents. And CDC quarantine station staff supported this order by conducting spot checks of a sample of arriving passengers. This order was just recently amended and effective earlier today at 12:01. And we've introduced a component related to vaccination. So vaccinated travelers will continue to have 3 days pre-travel to present the COVID test. Unvaccinated travelers will have 1 day pre-travel to get a negative COVID test. And children who are traveling with fully vaccinated parents or guardians will continue to have 3 days to get the negative COVID test. However, children traveling with unvaccinated or not fully vaccinated parents or guardians will have 1 day window to get fully vaccinated. And moving on to the mask order. The mask order was issued also in January of 2021, which required all passengers on public conveyances, airplanes, ships, trains, taxis, even ride shares, to wear a mask. And conveyance operators must require that all people on board wear masks for the duration of the travel. And operators of US transportation hubs must require people to continue wearing masks indoors at transportation hubs. The next order is related to the suspension of the right to introduce certain persons from countries with a quarantinable communicable disease. We talk about it as either Title 42 or 265. This order was initially issued in March of 2020, and it was followed up with a final rule that was published in September of 2020 as well. And the order allows for the removal by DHS of individuals who are not authorized to enter the United States. And this is reducing the crowding at ports of entry and Border Patrol stations at or near the borders with Mexico and Canada. The current order excludes non-citizen children from immediate expulsion. And since the order was initially issued in March of 2020, the average population within CBP custody has declined by 64% through October 2020 compared to March 2020. And the number of trips to community hospitals for medical care for detained individuals declined by 75% when compared to before and after the order was issued. There were also fewer trips to hospitals and other medical needs. Now we'll talk a little bit about the eviction moratorium. So during a pandemic, an eviction moratorium can be an effective public health measure to prevent the spread of communicable diseases because, among other reasons, they protect individuals from being forced to move into congregate settings. This initial order was issued in September of 2020 to restrict evictions of tenants failing to make rent or housing payments. The eligibility for the moratorium was restricted based on income and other criteria. Qualified individuals were also required to make their best effort to make timely partial payments to the extent possible. And in August of 2021, the US Supreme Court ruled that Congress must specifically authorize eviction moratorium. And as a result, the CDC eviction order was ended. One analysis of a state eviction moratorium estimated that the expiration of state eviction moratoriums resulted in a doubling of COVID-19 incidents in those states 16 weeks after the moratorium lapsed. And in the last several weeks, we have been busy with the international travel pivot. It removes the existing 212F presidential proclamations that apply to many countries, more geographically based, UK, Schengen area of the EU, China, Brazil, among others. And it implements a global suspension and limitation on entry of unvaccinated individuals, non-citizens who are non-immigrants. And it includes 3 orders as part of this implementation in this travel pivot. And I'll go into a little bit of detail on each of those. So the global contact tracing order requires all air passengers traveling into the United States, and including passengers that are just transiting through the US, to provide contact information within 72 hours of their flight's departure. And we are looking for 5 elements. we're looking name, address while in the United States, a primary phone number, secondary phone number, or perhaps an emergency phone number of a family member, and an email address. And airlines are required to collect this information from passengers and to retain it for 30 days, along with other relevant flight information, and to provide that to CDC within 24 hours of a request. And this information will subsequently be shared with state and local and territorial health departments for public health follow-up as needed and as required. The next one is related to the vaccination order, which is also authorized by the presidential proclamation that was announced on October 25th. So it requires all non-citizens, non-immigrants boarding flights destined to the United States to present proof of being fully vaccinated against COVID-19. The accepted vaccines are those who are currently either authorized for emergency use or approved by the FDA, or are emergency use listed or approved by the World Health Organization. This vaccination order does include a few exceptions. And as you'll see, I won't go through the entire list, but you'll see children of the age of 18, participants in certain COVID vaccine trials, persons with valid non-immigrant visas from countries with limited vaccine availability, which is defined as less than 10% of their country's population that is fully vaccinated, and others. I will note that those who are eligible for a U.S. national interest exception is led out of either Department of Homeland Security, Department of State, or Department of Transportation, rather than HHS or CDC. And as we were examining the differences specific to the global testing order amendment, that 3 versus 2 or potentially 1 day window, we were looking at the risk reduction that could be introduced by limiting the window for particularly unvaccinated or not fully vaccinated passengers. And so for unvaccinated passengers, the risk reduction will improve from 13.5% to 40% by changing that window of time from 3 days to 1 day. And the fraction of travelers who are fully vaccinated at arrival is also expected to increase as a result of the vaccination order and the presidential proclamation. So in summary, as you look across all of the different regulatory actions taken specific to COVID-19, you'll see that some of them are focused on the international realm and looking at ways to affect the international travelers that are coming into the United States. And then some affect both international and domestic travel. And then of course, the eviction order is domestically focused. Next, I will talk a little bit more about traveler screening and contact data collection and the challenges that we've experienced on that front. So if you look at this figure, you'll see that, and this is related to the various presidential proclamations that were geographically focused. So CDC initiated traveler screening and risk assessment in mid-January at the very beginning of the pandemic, and began to collect contact data for referrals to health departments in early February 2020. And these programs were targeted to travelers arriving from specific countries. And you'll see that noted by the dotted lines. And the figure shows when travelers from each country or region were added, and the presidential proclamations restricted entry from certain countries, such that foreign nationals from these countries were not allowed to enter to the United States. However, just to note, US citizens and lawful permanent residents and their family members were not restricted from entry. And you'll see a significant peak in travelers was observed shortly after the Schengen area was added on March 14th. Volumes of all travelers declined through the end of March, during which time global international travel volume plummeted and the number of travelers screened continued to increase incrementally through September. So for many of you, I'm sure you remember the Ebola outbreak of 2014, 2016. And if we do some comparisons across them, I think we see some interesting reflections. So previously, screening and data collection programs had only been considered for very regional outbreaks and not a pandemic. And of course, the Ebola outbreak was the most recent example. So over the 16-month period, about 38,000 travelers were screened and 29 were referred for evaluation. And of course, thankfully, 0 confirmed Ebola patients were collected or identified as a result of this entry screening. And of note, given the robustness of the data collection for each of these travelers, they were able to, 99% of the travelers were able to complete the post-arrival monitoring facilitated through state and local health departments. In comparison to COVID, over 760,000 travelers were screened over a 7-month period of time. And at the peak, almost 30,000 travelers per day underwent the screening and data collection. 9 travelers were confirmed to be infected with COVID-19. And because of the large travel volumes, data collection limitations, and states opting out of receiving the data, CDC was unable to transmit contact data for about 32% of the arriving travelers. And this comparison, I think, does a really good job of highlighting some of the limitations of CDC screening and data collection capacity during a global pandemic. CDC initially attempted to rely on contact data available through government data systems, but identified significant limitations in the data quality. CDC worked with DHS to deploy contractors to collect this contact information directly from travelers. However, this approach is not easily scalable when the volume of travelers increased dramatically when the Schengen area was added in March. And this resulted in delays with contact information being sent on to local health departments. And also to highlight a few additional challenges that we've experienced during the COVID pandemic. So while and Brian has done a great job of highlighting some of the accomplishments, we are unable to quickly surge staff as a result of the reliance on supplemental funding. We also had staff responding to Ebola outbreaks in both 2020 and 2021, while simultaneously fighting the COVID-19 pandemic. And this was challenging, though not a unique situation for the division. As Brian noted, there have been often overlapping responses that the division manages simultaneously. Lastly, because using our regulatory authority is somewhat new and in unprecedented ways during this response, it has added an additional level of complexity. And while we regulate airlines and cruise lines, and we put in parameters to reduce the spread of communicable diseases, we are also seeking to maintain close partnerships with the entities that we regulate, which does introduce and sometimes conflicting or at odds goals. And we hope to stabilize our workforce and prepare for future outbreaks and pandemics as we integrate these lessons learned over the last almost 2 years. And before I close, I just want to highlight that we have, I think many of you might be aware that in the president's budget for fiscal year 2022, it included a $30 million increase for the division. And this funding is critical to sustain the capacity that has been established through the COVID-19 supplementals and to expand the programs and the lessons learned that we've experienced over the last many months. And so when we focus in on this $30 million, what would we do with it? We would want to grow the CDC quarantine network. Pre-COVID, both Boston and Dallas quarantine stations weren't fully staffed, and they were covered by a nearby quarantine station and the region. So through the supplemental funding, we've been able to fully staff those quarantine stations, and we would want to maintain and keep them fully staffed. We are also considering adding satellite substations. For example, in Miami, there's also Fort Lauderdale Airport nearby. Perhaps there's a satellite office that makes sense given the large number of international arrivals into that airport. We also want to build a more modern and flexible traveler management program. We want to be able to apply these methodologies, and we realize that communicating with the travelers is one of the most important things that we need to do, is to ensure that the travelers understand what the requirements are before they get on that flight or get on that ship, and then what the requirements may be throughout their travel and post-arrival. We also want to make sure that we get that accurate and complete traveler contact information to facilitate that public health follow-up. And finally, we would like to accelerate the infrastructure and the development for CDC's Maritime program. Prior to COVID, we had a Maritime program that engaged with the cruise line industry, but as a result of the outbreaks early on in the response and the continued need to have robust surveillance and ongoing engagement with the cruise line industry, this is a need that I think COVID has amplified, the need to focus public health efforts and ensure that surveillance and through other data streams, we can make educated public health decisions to ensure that it's safe cruising for the masses. I will pause there and thank you very much for allowing us the opportunity to give an overview of both DGMQ as a whole, and then also highlight the most recent regulatory actions that have been taken as a result of the COVID-19 pandemic. I'll pause there and hand it back to Dr. Benjamin.
Hi, thank you, Jennifer and Brian. I think in the interest of time, what I'm going to do is go ahead and ask Marty if he would make his presentation. And Marty, when you make your presentation, you can also, I know you're going to talk about the recommendations from the last study, but also just talk about more specifically about what you really need to get out of this statement of task as you're going through that.
Thanks. Just coming off mute, and let me share my screen as well.
And I'm going to also acknowledge, just for the reminder committee, that this is a tough day for you guys. I know that this is the day that we're now allowing the flights in from Europe. So I suspect your staff are getting pulled in a zillion different ways. So thank you very much for being here today.
Yeah, sure. No, and sorry for joining a bit late. I was just coming off a press conference with Department of State with foreign journalists on this. So you're right. It's a busy day. Very welcome day. The pivot from travel bans to safe, healthy travel using our public health prevention tools is exactly where we want to be. Just confirming you guys can see the screen. Is that okay? Sounds good. Yeah, we worked for many months on getting this travel pivot together with regard to proof of vaccination, tightened testing requirements, the contact tracing, which those of you that were part of the original IOM meeting was originally a recommendation. It has taken us actually more than a decade and a half to get that in place. I've had the privilege of being in this role since '96 and have seen the sort of acceleration of emerging threats and now the syndemics of overlapping threats. And I think these also really complicate things. And I'll say more about that in the next slide. But let me just give you a quick run through, see if I can. This is the cover of the 2006 report. Let's make sure my screen is large enough for you all to see.
Yeah, if you could put it maybe in slide, if you could put it in slideshow view, you might you'll get a bigger.
Yes, I can do that, and I may lose my ability to see you, but that'll be okay. So the 2006 report. So after the SARS experience in 2003, or maybe I should say that beginning in '96 to the 2003 range, I would call the sort of first phase of the rebirth of the foreign quarantine service. As many of you know, came to CDC in '67. It sat largely dormant for about 30 years. The Institute of Medicine report, initial IOM report led by Joshua Lederberg, came out in '92 on emerging threats. I worked on the CDC response with many others, Ruth Berkelman and several others. And that came out in '94. '96, the foreign quarantine service was sort of reinvigorated and with Jim Hughes's direction, and I came over then. That first phase was about rebuilding something which had come to CDC with many thousand strong, with large numbers of ports and a robust international presence, reduced to just a few dozen personnel, and sat pretty dormant for '67 to '96. That first phase of accelerated emerging infections, we had infection threats, we had bioterrorism, we had anthrax, we had SARS. There was a lot of preparatory things going on, but SARS really kicked it off, and we engaged the then IOM, now the Academies, in developing this report. And it made some very concrete recommendations on the quarantine core, which said it should strategically lead US efforts as a tip of the spear to minimize microbial threats from travelers and international movement, which was a main driver. It should have sufficient financial resources as well as legal authorities to accomplish, and also additionally understand that we needed to leverage the work of a broad set of partners to harmonize authorities and functions, including ensuring sufficient contact data are available to share with partners during emergencies so that we could achieve the broad goals of prevent, detect, and respond to emerging threats that happened in migration or seeded by migration. It also made a prescient summary about supporting the health of migrants and refugees pre and post travel and enhancing the screening of animal imports. And recall at that time, right after SARS, we were on the heels of the introduced monkeypox outbreak from West Africa, giant Gambian pouch rats, and then spread to domestic prairie dogs. So lots of stuff, prescient stuff was laid out in that report. Additionally, and these are the two things I mentioned. Moving to the next one. Additionally, there was a recommendation to enhance competencies, the staffing size, the physical space, as well as employing technological capacity, and including the expansion of up to 25 quarantine stations from, at the time, I think in '96, we were dealing with just adding the sixth one in Atlanta for that Olympics. We also were, it was recommended that we periodically review our processes, our optimal locations, and maintain a flexible posture in this regard. There were additional recommendations that are shown here. This developing a proper surge capacity for emergencies with deployment of CDC assets, hiring plans, identified locations for isolation and quarantine, for making sure we could contain an introduced threat before seeding into the country, especially communication plans to interface with healthcare staff and the media. And in response to these activities, we have developed a number of protocols to support expedited hiring of our surge staff, including in cooperation with DHS. This may be slower than ideal if the supplemental response funding is not available in the time frame that the emergency is unfolding. We have struggled to find identifying locations to quarantine or isolate groups of travelers at airports, as well as sort of post-arrival. And in fact, compared to most other countries that we've seen in responding in this way, the sheer volume and breadth of arrival points and our travel volume has made it particularly challenging to have a place to isolate or quarantine groups of individuals at risk. And so recently, as Jennifer pointed out, we relied on housing at military bases when we issued our quarantine orders. This is not ideal, but the only large-scale ways to have this capability. But it does come with a number of trade-offs with our colleagues at DoD in terms of their ability to maintain their normal activities, both of readiness and response. This was done both with the repatriation from Wuhan as well as the cruise ship activities. HHS did have a contract, it does have a contract with the University of Nebraska for isolation. It provides for some nearby in the shadow post-arrival capacity for quarantine. However, it's very small in comparison, 20 beds or so for isolation and nowhere near the capacity to handle a repatriation effort, whether it's extracting US citizens from a nidus of infection or off of a cruise ship. This is an outstanding issue that we have had a really hard time to address. We have been asked to, in the recommendations, about a research agenda that examines basic public health interventions for developed use in the system and reevaluate current practices and procedures looking forward to future emergencies. I will say that we have done this both in peacetime and in crisis response time. And so, for example, we've expanded the research capacity through the division. We have a number of additional cooperative agreements with research partners. Examples include global surveillance networks through global TRAB EpiNet. I know Ed on the panel has been a key player in that. And of course, the GeoSentinel network, which is going on more than 25 years, which is a global network of clinics that see mobile populations. We've increased our ability to conduct risk assessments for future microbial threats. Even during a pandemic, sometimes we aren't able to pivot as quickly with the learned science, given the many other factors that go into place in screening. So we were aware quite early of the limitations of entry screening for SARS-CoV-2, in contrast to some of the other experiences where entry screening for symptomatic, more blatantly symptomatic cases was more effective, or at least easier to accomplish, both in volume and in distinguishing or identifying cases. With this pandemic, with more than 50% of the infections being asymptomatic, it was remarkably ineffective. But the actual pivot away from entry screening took many, many more months in order to accomplish over the course of that period of time from, say, March of 2020 through the following September. And so entry screening went on longer than some of the research and the tools that we were evaluating would happen. And this goes into play of the number of factors which sort of dictate the approaches and the policies. In terms of the development of tools, we have, since that time of this report, had a quarantine activity reporting system. It catalogs all events that occur at a quarantine station by the staff. It does follow-up. That is in the case of additional diagnostic tests. We document the impact of screening. We look at the follow-on oversight and monitoring evaluation of regulatory orders, as Jennifer indicated, and other activities at ports of entry during each response. We have been able to tailor and scale back the timing at which we turn on a series of bounded screening activities with prioritization for screening at the source of an emerging outbreak, monitoring the movement during the transport into the US, and also the entry screening or post-arrival follow-up. The post-arrival follow-up activity has been limited by a failure to get an electronic contract tracing system in place until essentially effective for the first time today. We've developed an electronic data reporting system that documents the medical exams of all incoming immigrants and refugees and other classes of immigration, special immigrant visas, special evacuees, like the Afghan evacuation situation that was alluded to by Brian and Jennifer. Just to give folks an example, this slide shows the growth of the quarantine network since your report in early 2004. And as you can see, we've added 13 additional quarantine stations at airports and land border crossings as recommended. There are 5 airports for which quarantine stations were recommended in the previous report: Charlotte, New Orleans, Phoenix, Denver, Kansas City, that are not included in the network. And it was determined at the time that the additional 5 locations would be better used by augmenting our international expansion. And so we focused on establishing both multiple shifts at the key ports of entry, going from 1 shift to 2 shift, but also building out the international field offices in Kenya, Thailand, and Jordan to support refugee and other migrant activities, as well as field staff deployed to Mexico City to support cross-border health issues. So we held at the 20 and expanded internationally at origin locations. This is a look at the FTE expansions broken down by headquarters in blue and field in orange. And you can see over that time, the first sort of 6 years or so after the SARS event and the issuance of the report, where the field staff had been augmented in particular. The headquarters staff remained relatively flat, and it shows the modest expansion of the workforce. Most of the staff added at this time were smaller than the, in headquarters than the field increase, but the total staff in time, permanent staff doubled between 2003 and 2006 as a result, among other things, of the very helpful original report. However, the next slide is a little bit more sobering in looking at trends. So this is an 11-year emergency response and funding trend. And I think Jennifer made the point, as did Brian, that often the emergency funding is very much delayed in comparison to the onset of the event. And frequently we are called upon to act and surge before there's any guarantee of funds available. So in the previous years, you can see from the light blue and orange shaded bars here, our core budget has remained fairly constant. And we receive this in dark blue, the surge funding that comes on that allows us to surge the support. And these included efforts like the West African Ebola and the COVID-19 response. Our total staff size during these surges includes a number of different mechanisms of hiring temporary contractors, what we call term or short-term FTEs. They can surge sometimes by as much as 200 to 300%. The majority of the surge staff have been deployed to the field stations or in support thereof. However, there's very uncertain funding streams, and they often lead to a yo-yoing of available funds and then the removal of those funds. But the expectations for the kinds of services that are provided tend to be incremental and build on one another, while the funding is very intermittent and transient. This can also lead to a lot of staff instability when staffs are cut back to the baseline, but expectations remain high. And as you can see, we also had staff responding to Ebola outbreaks in 20 and 21. We also had, and this is what I would refer to as the syndemic trifecta of the largest ever migration across the Southwest border from the Northern Triangle and further points south in South America. And then an unprecedented humanitarian crisis in Afghanistan, which led to the largest US humanitarian evacuation of Afghanistan under fire in US history, where over 100,000 Afghan evacuees have been brought to the United States and are screened on military bases across 8 bases in the US in sort of a record amount of time in terms of health screening, vaccination testing, COVID testing. In addition, these congregate settings across the US with this many Afghan evacuees has also required vigilant surveillance systems and outbreak control and technical assistance from CDC beyond simply the implementation of screening and vaccination requirements. And most of the overseas medical exams and screening had to be waived in this emergency by the exigent circumstances, and appropriately so. There was not time to scale up and complete these things overseas. But that waiver had led to a measles outbreak, introduced measles outbreak in a vulnerable population that was unvaccinated in living in congregate settings. So these are essentially the challenges that happen when pandemics occur in this fashion. And just to give you this kind of summary, where we left off on staffing in 2008, shown in gray with a broken timeline here, and then with the staffing over the last 2 years, contractors are shown in orange, and the term FTEs and fellows, where the permanent FTEs are in the blue. So this surge staffing has been enormous in volume in order to deal with the last 2 years of complex humanitarian crisis, as well as the COVID pandemic. The supplemental funding we see, as I said before, is delayed, and it really delays some of the primary response capabilities. So DGMQ is actively involved in 3 incidents concurrent with the pandemic: the COVID response, the response on the Southwest border, and the response to Afghanistan. And I foresee in the future more events like this: climate generated forced displacement and internal displacement, migration emergencies that are triggered by all the hardships of protracted pandemics, et cetera. So in terms of the scope of this work for this committee, we would like and really need very much your help in identifying effective interventions and best practices that can be adopted moving forward as we look to
what I have called with my team the DGMQ 3.0 pivot. What does the next 5 to 10 years look like, and what should be in the lane of DGMQ work, CDC work, and others, both what could be adopted in the US specific context for future pandemics, but also given the complexity in the syndemics, as well as capacity restraints, what are the best tools and practices to mitigate disease introduction, safeguard mobile populations that need very much protection and are often the most vulnerable during a pandemic, both domestically and globally, and protect our need to move with respect to travel, tourism, supply chains, all the kinds of things that we recognize now that are contingent in a globally interconnected society. How do we implement innovative data systems and analytics for both forecasting and monitoring and evaluation? The constraints that we are coming across is scaling limitations due to health screening and data collection, but also the challenges for rapidly and real-time gathering, analyzing, reporting, validating data, dealing with the interoperability challenges between agencies and partner networks, and supporting the public health action. And then policy challenges related to the management of movement restrictions in very large groups, as well as an unprecedented reliance on CDC and DGMQ in the issuance of federal orders for pandemic disease control or movement control. We also would like some help reviewing the needed changes in CDC's infrastructure and regulatory authorities. How do we leverage other innovative approaches in data systems and analysis to mitigate these? What are the challenges to implementing regulations and recommended measures? We can conceive of them, can draft them, put them out there, but we just do not have a scale of workforce to actually do implementation. So we're highly leveraged, depending on other partners across the interagency, to oversee an implementation. And these are very, very controversial measures, which have been subject to numerous legal challenges. So we are involved on a daily basis in addressing court challenges, appeals, movements of these kinds of things, injunctions, temporary injunctions, stays, the scope and the responsibilities of being an active regulatory division and agency at CDC has proven to be far outstrip the scale that the skill set of the agency has. And we're often seen as the agency to implement things that are even on the margins, as Jennifer talked about, but are necessary from a public health perspective, like the eviction moratorium when Congress didn't reauthorize that. How do we support health departments and partners in the mitigation efforts? And how do we deal with these types of policy challenges? What's the optimal staffing and scheduling? We find that we're working as a 24/7 component, traditionally as a one shift, 8-hour daytime entity with staffing. We did double that in the field, but we have not been able to double that type of staffing at headquarters. And so people for 22 months now at headquarters have been working largely 2 full shifts a day, every day, sometimes longer for leadership. And it really is become a very difficult thing to sustain in the current frame. So with that, I thank you and would turn it back to you, George. I hope you get a feel for why we really need some help at this point in this juncture, as we think about what the division was in '96 when I came and where we are sort of in the post-COVID view, and input from this committee will be tremendously helpful. I know that there's many familiar faces and on the committee and some new faces with lots of talent and expertise, and I look forward to benefiting and hearing from all of you. Thanks.
Well, thank you. We have a few minutes for a few questions. I know we're running a little bit behind, but since we have Marty here, and now we're going to have other CDC folks speaking to us from the division later, I think on another day. But let's, if you have something very focused on statement of tasks or something that's a burning question, why don't we ask those now? Michelle? In fact, if we could use the raise hand function, if that works. If not, the I gotta speak works as well. So, Michelle.
Hi, Marty. And first, I want to thank the CDC. You've done a Herculean job. But one of the issues that came up during this epidemic was the harmonization of public health messaging. Even in my own state, one county gave a different recommendation than the other county, and they certainly weren't only going by CDC guidelines. And so can you just give us an idea of how this state and county independence really can be harmonized with how CDC gives guidelines?
So it's a great question, Michelle, and it's a huge challenge. I will say it's not a new challenge. I see Howard on the panel, and we'll hear from him later. Howard and I, as folks may remember, back in leading up to 2005 to 2007 and putting together a pandemic preparedness plan, looked at the 1918 experience in great detail. 43 cities over 1 million in size. How did they fare with deaths? And how did they coordinate at the local, state, and federal level? We did observe a number of really important things about what works and what doesn't work. Unfortunately, many of those lessons proved unlearned as we went in to this pandemic. But one of the sobering ones was internecine rivalries will hamper the ability to get an effective public health response. And we fully recognize at CDC that a pandemic is a whole of society response, and it requires coordination on what I've called the sort of 4 main points of the diamond. You know, the public health perspective is just one. There's a political lens, there's a private sector or economic lens, and there's the population's lens in terms of what they perceive to be the threat and how their behaviors would or would not change. And unfortunately, I think internecine rivalries drive a big arrow right through the middle of all of that. And what happens is the bilateral tensions between the public health perspective and the private sector, needs, or the political or the population's needs, and the rivalries at local, state, and federal, if they're not well aligned, we will not be able to have an optimal response. And we've not seen a level of division, at least in my experience in this country, that we have now. But the idea that there's tension or failure to be able to align that, whether it's the communication message or the behavioral response, is not new. And I wish I had a clean answer to your question, but I don't. And I think we all have to figure out how we're going to do better, but it's really, really hard.
Is there a fix?
I don't know if there's a fix. If you look at this from a global perspective and you look at countries that do well versus those that don't, there's a huge role for a coordinated leadership. If you look at, and again, it's not always fair to pick Australia or New Zealand, island countries with small populations, or even, other countries where populations are under 10 million total. But there are formulas for what works well in getting cohesiveness. How to do that in a country like ours, as big as ours, with as much diverse opinion, and a lot of state autonomy by intent. And it's true that at the federal level, we have jurisdiction for interstate movement, but we've had a really hard time even applying what we know to be good principles around international travel practice by issuing domestic travel advice that was extremely sensitive. And we also have 2 very different administrations that the pandemic started in and where we are now in terms of the willingness, to be involved in state-based or even more local decisions. And quite honestly, we even see a situation where this divisiveness is happening within a state where public health police authorities are largely state-based. The amount of division between a governor and a local community is also really hampering our ability to respond. I think it's a sad state of affairs, but I don't know what the fix is.
So here we got a whole list of folks. I've got Ed, Alessandro, Stephen, Larry, and Jason. Does that make sense? Ed?
I'll be quick. Marty, thanks. And thanks to the CDC. You guys are certainly having to juggle repetitive, simultaneous, and complex issues. I guess I'm just trying to get my scope of from the CDC's perspective, what is the vision here? Because the title, at least from that I see on the sheet here, is the effectiveness of the quarantine station network. But what I just heard was a much more holistic approach. And I do notice that on the detailed statement of task, that there's a conjunction there of an overview of DGMQ and the network. Is it really what would help the CDC's perspective here? Is it the big holistic thing or the stations?
I think what we've found, I mean, when we first started putting out this contract to get this, we were trying to figure out how we navigated the station's role. But what happened since we put out the request was the southern border became, tremendously overwhelming. We carved out, as soon as the administration changed, we carved out the unaccompanied children for admission. But that kind of irregular migration travel ends up being a border-specific challenge. And then Afghanistan happened. We were planning for a much longer sort of phased landing or a softer landing on that movement, and then it came to a crunch. And so both of those things occurred, and it was hard for me to avoid understanding that the quarantine stations actually have been playing, as well as the immigrant, refugee, and migrant group, and our regulatory group has been pulled into all of that. And I don't really see how we could address one of it in isolation with respect to discretionary travel, because every one of the air, land, and sea environments has been affected by this endemic. And so that's going to be the reality for this division in the near term. And I think it would be more helpful to get input from you all on what the integrated approach looks like, rather than a particular port of entry, because we have people coming through between ports legally, irregular migration and regularized. But even when the Afghans were emergently evacuated, whether directly or out of what are called lily pads in Europe and the Middle East, they all came into two ports of entry where we had to stand up a surge, one in Dulles and one in Philadelphia, before they went to the 8 to 10 military bases. And we did testing and vaccination and all those things together with state and local health departments at those designated ports of entry. That plan is still the US government plan, is to find fixed points of entry for migration emergencies, whether that's one complicated by infectious disease or just a conflict evacuation or potentially a climate evacuation. So I don't see how we disentangle these types of issues.
Oh, Sandro.
Yeah, I'm going to touch something that probably is not easy to answer, but you have shown many times the budget trajectory. And if we look at the budget in the last 2 years, you have this big jump that is the emergency budget, while if we look at the FTE position at quarters, that you didn't have that much, how to say, buffer to improve. So my question here is, are you operating now on the basis that this emergency budget is just going to disappear and you have to go back to normal? And how much of according to you, you have listed a huge amount of activities and experience, and I'm sure people with boots on the ground in places. How much of this will be just vaporized at the end of this emergency budget? And I know that.
Well, those are things I can't tell you with confidence, but I can say is that, we really laid it down and said we haven't had a base increase that exceeded, sort of the value change of time since the 2008 frame. And we've asked again in this budget, we have a $30 million proposed increase in the state and House markups, but we're still waiting to see how the 2022 year plays out. We have very little no-year emergency funds that carry over and stay nested. That's a huge challenge. And then these surges, especially the COVID surge in terms of its scale, both money and people, puts a huge strains on the infrastructure, even the HR and the hiring resources and everything else. So it doesn't become timely. And I've been arguing for years, I hope this pandemic is, proof positive that this is the look of the future or the near future in public health, that we have to have a much more robust infrastructure to handle multiple theaters of engagement and complex emergencies. And they will come, migration emergencies will come from climate issues as well as infectious issues and political conflicts. And I just don't know how we can continue to do this on the yo-yo funds, where the yo-yo swings are often months delayed from the actual event, but the response needs to be fast. I do know that the prior report that the academies gave on this were very helpful. That 04 report did translate into an increase in division resource budget from Congress in 2008. It took 4 years, but we got there. And unfortunately, that's the story. I think we don't have that kind of time on the clock anymore.
Stephen.
Thank you.
I'm sorry, was I next, George?
Yeah, yes.
Yeah, so Marty, I have two questions, and one of them specifically is about the scope of tasks, because if I remember, one of the things that it mentions is asking the committee to examine other countries' systems for quarantine and for screening and entry. And I'm wondering what the intent behind that was, and if you have had thoughts about other models that are out there that the committee may need to examine. And then my second question was that you mentioned, especially with the surge, that you've been using contractors. I don't know the details of who these are, but do you have pre-existing contracts that you can just sort of jump right into that are already there, where you have individuals that are trained as your force enhancers?
I'll take the second one first, Steve. What we have learned is the need to have pre-positioned contracts that can surge, because the ability to turn on things at ports, people need special approvals and badging to be able to operate in secure spaces. And that was often too delayed. So we have sort of pre-positioned a set of requirements, and we have contracts now that we can dial a bit in that regard. So they're a little bit faster to turn on and off. Usually at the very front end, we're still dependent on other parts of the CDC workforce in that acute phase, and then we roll into the contracts. It's better than it used to be. It's not perfectly designed because the people themselves still need to be trained. We are looking at pre-trained groups in other settings that we could call back in, like a reserve corps, which I think would be helpful. In terms of the other countries' experiences, they're widely varied. Most everything is smaller in scale, but there is some notable things that were we able to have done earlier might have made a bigger difference. For example, Canada had a situation where they quickly narrowed their points of arrival and had a federal capacity to do a lot more things post-arrival besides just the screening, but be able to isolate and quarantine the arriving group pretty quickly, do a follow-on testing, do surveillance for strains, and detect variants sooner. It took the US longer to scale up its variant surveillance capacity. Notably, all the major variants of concern right now have been imported variants where the virus circulation has been higher. But not to say that that's a guarantee, but it is a reason for being able to do more certain types of surveillance at ports of entry that almost every other country Western country that was putting effort into this was able to do better than we were, I would say. If you look at the strain surveillance capability of travelers in both in the UK, in Canada, and some other places. I think we're always going to be stuck with what's doable by scale and what's acceptable as a federal role versus a state and local role, without getting into the chaos that Michelle reported on the lack of homogeneity in approach. But those are some examples. I think that the other issue is to look at places that also have federalist systems. How have they achieved more harmonies with provinces, for example, Canada? But there are other situations where there's a federal state kind of sharing of responsibilities, and what has been required to get that coordinated, and how have they divided some of those roles. Those are the things that come to mind. I think there are no perfect comparisons. It depends a little bit on the access, but the nimbleness, the flexibility, and the coordination are really pretty key issues. And how much can we expect from states when they're overwhelmed, with autochthonous transmission within their state? How much is even reasonable to expect on the importation side? Or is this the kind of thing that we can only expect to be able to accomplish on the leading edge at the very beginning or the tailing edge as a wave is down quite low? Is it something that can be done at all during, you know, surges and peaks in transmission? Those are some of the questions.
This is Brian. I just had one quick thing to add, was also maybe how to use, other countries have used technology to leverage the process.
Thanks, Brian. Larry Gostin.
Well, first of all, thanks so much, Marty. I mean, for all you've done for so many years. I have two quick questions. The second one will be, well, they might both be hard to answer, but for different reasons. You know, the first one is that, you know, a lot of us have had the sense that travel rules, not just in the United States, but everywhere, lack an evidence base. That we don't know exactly, you know, what is the optimal time to restrict travel, under what conditions, when do you let it go, to who do you, to which countries do you apply it? Do you pick and choose among countries? Because that's what we did do, and now we're not doing that. So if you could advise us first about, you know, how we can use scientific evidence to kind of inform judgments about that, I think it'd be enormously helpful, not just for the US, but globally, and WHO in particular, and the IHR. The second is more is a more awkward question, maybe more awkward to answer, Marty, because, you know, I've known you for, you know, we've decades, and you're, you know, I mean, without, you know, falsely saying it, I think you are, you know, among the smartest people that I know in this area. And watching CDC, it's hard to get the impression from the outside with things like, you know, cruise ships, travel rules, eviction moratorium, and things like that, that CDC wasn't buffeted about a lot, you know, between, you know, Congress, the White House, different administrations, the court system, also WHO with conflicting views. You know, is there a way we can make suggestions that would make this process more rational, less political, more scientifically driven? Anyway, those are my two questions. I know they're hard to answer.
Well, you always ask the great hard questions, and I think I welcome the role that you play in that international dialogue. So look, the latter is a matter of, in some regards, of public record. There's plenty that you can read on the tension between politics and public health that occur over time. And as I said, in reference to the work that Howard and I did many years ago, unfortunately, that's not necessarily new. And I think there probably are recommendations that could be made that create some buffers between the kind of direct amount of interference that comes to play at times. But public health is an inherently integrated political and private sector and public's perception issue. And so how we do that better, I think, is what Michelle was getting at. I don't know. I really appreciate all the smart minds. I have some ideas that, you know, we can discuss sort of offline in a different forum. But there's no doubt about that the tensions in those dimensions are strong, and they do essentially affect the way best scientific public health practices can be put. I alluded to one, which is, you know, we saw, and this gets to your first question about entry screening and other kinds of things, or travel bans even more so. We knew long before we got the pivot that wasn't the most effective approach. But there's often a adherence to something that falsely feels safe when it's less safe, and not necessarily the ability to implement quickly the things that we know are better tools. I will say that in the very beginning, when we're faced with a newly emerged virus, the humility that we need to maintain about understanding what are the modes of transmission, whether there's pre-symptomatic or not, whether it's airborne or not, whether it's going to be detectable through a screening approach or not, with known pathogens that we've seen over and over again, we probably more quickly can fine tune the types of tools that you can use in that setting. With an unknown pathogen, it took a while for the scientific community to come to closure on a few things about aerosols, as well as on pre-symptomatic spread and breakthroughs. I mean, all these things you learn as you go along. The need is to be able to pivot. I don't think there's one answer entirely. Whether it was reasonable to have travel restrictions at the very, very beginning while you gather data. As you know, Larry, all our pandemic planning suggested you'd buy at most 2 weeks, but you need to stand up attention of the world. And I will say the Southeast Asian countries that had to deal with large migrations during Chinese New Year used border screening early to know that exported cases were occurring. Even if the yield wasn't high, just knowing that risk is there is important, because sometimes that may be the only way you find the very first cases, by getting surveillance going early. And then until you can put up alternatives to bans and restrictions, people are stuck with the fear of the magnitude or the severity of the pandemic and not knowing what to do. I do think in general, they're very, for respiratory pathogens that can move this in the way COVID has proven to move, they're very limited value to bans other than just debulking, the volume. But I do think the pivot that we've achieved finally today, November 8th of 2021, but many months in the making and arguing and trying to navigate and get the whole of society wrapped around and coordinated and on board with, are safer, more robust, more reasonable approaches. And they're strategically targeted around prevent, detect, and respond, use our best tools, proof of vaccination, testing, which has to be vax and test, not either or, because there are two goals here: preventing getting infected people into the travel circuit itself, but also making sure that the risks are reduced among those who can continue to safely travel. But also, it's not vax alone in terms of mitigating the pandemic where we are. There's a high degree of variability of global vaccine accessibility and distribution. And even in places where there's an abundance of vaccine, there's still plenty unvaccinated people. And so there's a need to marry the vaccination and medical countermeasures with traditional public health and social measures in the right balance. I think we're still learning what the best science is on that, but we're so much further along 22 months into COVID than we were in January of 2020. It's just, how quickly can we apply those? How quickly will they be accepted by population politics and private sector? Those are tougher questions to answer. So I know I didn't answer you directly, but that's sort of my
No, it was
reflection.
very, very helpful. And I agree that the pivot is a smart move. It's late, but it's smart.
Well, we've got a time challenge right now. I know we have to get on to our conflict of interest. Marty, are you going to be on next week?
Yes, and I think I can look at the calendar. I think I have some time, if you request it, to engage in some more questions after whatever break you have. But I will be on both on the 8th, I think it's the 15th and the 18th as well.
Okay, well, we'll probably get on with that. And if I could ask Jason and maybe Marcy, is it okay for me to hold your questions until next time we talk with Marty, or is that something you really need to have done today?
Sounds good.
You're both okay with that?
Yep.
Thank you very much for being flexible. So folks, we're going to take a 5-minute break. We'll be coming back. We'll be in closed session, and we won't be recording that part. So I want to just thank you all. I want to thank our colleagues from the CDC. That was quite informative. And we'll be back in about 5 minutes. Sound good?
Thank you, Georges and Julie. I really appreciate the help, and it's great to see so many friends and colleagues on this group. Looking forward to your future engagement.
Thank you so much, Marty.
Yeah, bye-bye.
And Mandy, can we end the live stream?
Laptop once you have it.
Okay, the live stream has ended.
And thank you all to the CDC folks. You'll have to sign off now. And then we'll probably be letting you back in about 1:15 for the next public session. And yes, and please do come back everyone promptly because we probably don't have